Diabetes mellitus, commonly known as diabetes, a condition where there is insufficient production of insulin from the pancreas or cell resistance to insulin will develop over time. This will alter the body's ability to absorb glucose from the bloodstream and into the cell. The presence of insulin acts like a key for glucose to enter the cell door. Without it, the body's fundamental metabolic activities are affected due to glucose being a crucial component for energy production inside the cell and can induce hypoglycemia or high blood glucose as glucose is trapped in the bloodstream. Type 1 or insulin-dependent diabetes will typically manifest in children but can develop at any age. It refers to the destruction of pancreatic beta cells, the job of which is to produce insulin. In 90% of type 1 cases, a patient who is genetically susceptible will experience a triggering event, such as a physiological stress or viral infection. During this event, there is a production of autoantibodies, which are antibodies that mistakenly target healthy cells, which destroy the beta cells of the pancreas, leading to a decline in insulin secretion. This means that we lose the key for glucose entry into the cells. Because the cells do not have access to glucose for fuel, this results in unnecessary gluconeogenesis, which is a breakdown of fat and protein, also known as catabolic metabolism, for glucose to produce ATP or energy. Type 2 or non-insulin dependent diabetes occurs from chronic high blood glucose levels, leading to a deranged insulin secretion from the pancreas into the bloodstream. Insulin receptors on the target cell wall eventually develop a resistance to higher levels of insulin. Glucose becomes trapped in the bloodstream as the key that we had will no longer fit. Imagine the high levels of insulin blowing out the fuse box of a house. Even though there is enough power being supplied by the power station, the lights and appliances in the house will no longer work because power cannot get through the broken fuse box. It's important to note that even though there is no autoimmunity to beta cells in the pancreas, a type 2 diabetic may become insulin dependent from the exhaustion and damage of beta cells, attempting to constantly secrete insulin as a response to low levels of glucose reaching tissue cells. Hypoglycemia manifests when blood glucose levels are higher than 8 millimoles per litre and can occur when a diabetic patient forgets to take insulin, promoting glucose entering target cells or glucose converting into glycogen in the liver. Excessive amounts of glucose can cause an inflammatory response which harms the endothelium or inner lining of the blood vessels, resulting in vascular remodeling, increased arterial stiffness, and atherogenesis or plaque formation, increasing the chances of comorbidities such as cardiovascular disease or stroke, retinopathy, which is blood vessel harm in the eye causing leakage into the retina, causing vision issues, neuropathy, causing an altered pain response from low blood supply into the neurons from harmed blood vessels. Finally, slow healing sores from reduced circulation into the peripheries from harmed blood vessels, causing pressure sores that can turn into ulcers, which take longer to heal from reduced blood flow, often leading to infection. Secondly, diabetic ketoacidosis or DKA can occur, more likely in type 1 diabetic patients below 45 years of age with very little or no insulin production with a blood glucose level higher than 13.8 millimoles per litre. The body begins to break down proteins and fats as a response to tissue cells not receiving enough glucose, known as gluconeogenesis. The breakdown of fatty acid from lipids produces a large amount of ketones which are acidic, inducing metabolic acidosis over a few days. Flagship symptoms of DKA are fruity breath from the presence of acetone, a type of ketone, an increase in rate and depth of breathing known as Kurzweil respirations, and an attempt to blow off CO2, reducing acidosis. Finally, hypoglycemia hyperosmolar state, or HHS, manifests with a blood glucose level higher than 33.8 millimoles per litre and is common in older non-insulin dependent patients where there is just enough insulin to drive potassium into cells, inhibiting gluconeogenesis, but not a good enough response to drive glucose into the cells. Massive amounts of water will travel down the osmotic gradient from a large amount of glucose in the blood. This will cause the patient to transiently become hypertensive. When the water is excreted in the kidneys, acute severe dehydration will occur, resulting in hypotension and potential hypovolemic shock. Signs and symptoms of both conditions are very similar, with hypoglycemia, nausea and vomiting, neurologic symptoms such as fatigue, stupor, and potential unconsciousness, and hypotension from acute dehydration that is more severe with HHS. Hypoglycemia manifests upon a blood glucose level lower than 4 millimoles per litre and can occur when there is too much insulin promoting the liver to turn glucose into glycogen. For a type 1 diabetic, this can occur from an insulin overdose, missing a meal, or excessive amounts of exercise. Signs and symptoms include cool, pale, and sweating skin, tachycardia, hypotension, polyphagia or excessive hunger, tremors, blurred vision, and are easily irritated. In severe cases, a patient can become in a drunken-like state or unconscious. Being left untreated, the brain will be starved of glucose, causing death. Diabetes is common in New Zealand with 250 diagnosed patients and an estimated further 100,000 undiagnosed. With the world-leading obesity rates, type 2 diabetes makes up 90% of these cases. Statistics also see diabetes as more common in the Māori and Pacifica population.